Hello everyone. So today we are going to do a topic presentation. The topic is hypoxic ischemic encephalopathy, and of course is pertinent to neonates. So basically what it is, it's really stress and anxiety for both parents and NICU staff. My journey started long back, and interestingly in 1999 I wrote a letter to editor to pediatrics and stroke about when this hypothermia was really starting, and it got published and I got so excited. So what is neonatal encephalopathy? So it could be stroke, HIE, and infections and brainstem damage. So remember that HIE is only one part of neonatal encephalopathy. So preferably neonatal encephalopathy is a better word to say rather than saying hypoxic ischemic encephalopathy, as the word entails hypoxic ischemic. It's really difficult for the family to understand. If you say encephalopathy, that is inclusive of other things as well. Anyway, HIE is one of the encephalopathy. So it's a type of brain dysfunction where the brain experiences a decrease in oxygen and blood flow, and then the cascade starts. So I'm just going to walk through very quickly through some slides, and thanks to references and Google images. So basically pathophysiology is, of course, the blood doesn't reach the brain, and due to whatever reason, is abruption or cord accidents. So the whole cascade starts here, and the whole cascade starts. So primary injury, latent phase, secondary phase, and tertiary phase, and then the reperfusion injury starts, and then of course cell death. So you can see here the green window, 1 to 6 hours. So I think this is the window where we can help the patients. This is another slide reiterating on the same thing. Another slide saying the same thing in a different way. So let's see how placenta plays a role. So this is a nice study published, or a review you can say, is published in Seminars in Fetal and Neonatal Medicine. So here you can see that how different pathologies can have different impact on placenta, and one should be the part of HIE as well. All HIE babies should have a placental pathology done. So what is the clinical manifestation? Of course, Cernat classification is the, I can say, a gold standard before you put any baby on hypothermia therapy. So the acronym how we can remember is CAP-TAP. So conscious level, activity, posture, tone, autonomic nervous system, and primitive reflexes. Remember that 3 of the 6 categories have to be scored moderate before we can label the baby as a candidate for hypothermia. So again, the same thing, how the whole cascade starts with respiratory depression, and ultimately you see some multi-organ system involvement. So that's what I say is a lot of stress to the family and physician to manage these type of babies. What investigations? You can do either a 24-hour EEG or an amplitude integrated EEG, whatever your institution has, and this is the screenshot from an image. So these are the different ways you can monitor the brain waves. Of course, if you want to do a EEG, you have to have a neurologist read it for you, and these are the 2 examples. Imaging. So there are, MRI is the standard to look at. Usually we wait 3 to 7 days to get an MRI, and MRI is very classic in terms of HIE findings. So again, this is another study from NICU. They have a score, and they said a score of 6 is really detrimental in terms of a long-term outcome. So how do you manage? Like I said, it's a multifactorial problem, and all organs are affected. So this is a nice slide. Take a pause here, and then you can look at whatever you have to support honestly all the systems, and again see how the whole cascade play a role. Follow your institutional protocol. Most of the institution have a protocol. On the right side there's an insert that shows how to go along with the algorithm, but basically any baby who has a history of antenatal incident and has a cord gas which is pH is less than 7 and had seizure automatically qualifies for surgery, hypothermia therapy. But if seizure has yet happened and still baby is okay, then probably you can wait. But again, you only have 6-hour window. There's a calculator you can use, and then you put some number and it will tell you if it's included. But again, you have to be very critical. It's just a difficult decision to make, honestly. What does hypothermia does? Basically, it just cools the baby, slows down the metabolic rate, and help the healing process. What are the complications? So cooling is not benign, it can cause many of the problems as listed in this list. Now the question is neurodevelopmental outcome. There are studies showing that, if you start hypothermia early, you can prevent severe HIE. But remember, if it's mild, really the hypothermia does not really help. And see here how the data changes. And this is another paper saying the same thing. Another paper from Sweden, another paper from US, another one from Italy. So basically, HIE, you have to make a call within 6 hours, and sometimes it's very difficult. So what are the future holds? You can have some biomarkers that can help you in deciding the course of HIE. And this is another article, so take a look at it. So you can do some neuroprotective, thing. We have heard recently about EPO and HIE, and the paper was published in New England Journal, and we all know that it hasn't really showed any promising results. So these are other therapies, which could be done as a neuroprotection, and these are the mechanism of action of different, neuroprotective agents. Just pause the slide and take a look. This is another paper from Archives, and you see how the mechanism of action is there. So again, interesting concept. If sometime there is a genetic susceptibility to HIE, so it's not only the antenatal or prenatal or antepartum event, it could be a genetic susceptibility. And of course, combining everything. These days, everything is omics, so genomic, epigenomic, proteomic, metabolomic. So basically, it's anything that plays into the role of neonatal HIE. So what is the roadmap? Basically, most of the events start prenatally, and then, like I said, first 24 hours, are very important, especially the first 6 hours. So some question is still on therapeutic hypothermia. There are some unanswered question. So there is insufficient data really that how in mild cases, hypothermia works. But like I said, for a neonatal team, it's very difficult to make a call and hold therapy, with a lot of legal implications as well. But this data shows that how it's really questionable. And also post natal, there was a case where a patient went for OR for just hernia surgery, and then was coded. And so, would you do hypothermia in this case? Is it justified? Data said you can do it, but again, like I said, results are not that promising. And you guys can read this slide. So what about in sudden unexpected collapse? Again, the data is questionable. So you can do some QI in HIE. So this is the case presented, and a patient was depressed. There was a tight nuchal cord, and you can see the cord gas was not bad, but arterial gas was bad. So based on this, would you start the patient on hypothermia? So in this case, it was initiated based on the clinical assessment. Sometimes it's not only the cord pH; it's your assessment within 4 to 5 hours. And if baby started to have seizures, and then probably you'll be better off putting the baby on hypothermia. So remember, there are some pitfalls in this, in this ARNET. Many people just write, other stuff like, so not included is hypertonia, gag reflex, caudal reflex, rooting, knee jerk, ankle jerk, meniscus. Don't do that. Just follow the standard, examination like CAP TAP, and you'll be okay. Case 2, again, almost, now this one has a cord pH which was acidotic. So this was a patient who was sent to newborn nursery, and they were calling about admission to NICU and starting therapeutic hypothermia. So, but everything was okay. So following this algorithm, the patient was managed. And the point which I want to make, that cord pH is not a solo criteria to initiate, therapeutic hypothermia. Just make sure that you should follow closely, and basing on the scores, neurological assessment is the most important part in all these cases. So this patient was managed conservatively, and baby did okay. Again, remember, there is a 2x2 table for everything. You want high value care really. If investigation is needed, you should do it. If it's not needed, you should not do it. So that's why therapeutic hypothermia is a difficult call to make, because if it's needed and you miss it, you're taking a lot of risk there. So this is again, my journey continues. So if you guys have time, read this paper. Then I wrote some comment on archives of. This is another interesting case. This is freely available. It was published in Newborn Journal. So this describes a case where a decision was not taken to do HIE, and there was a big commotion and back-to-back discussion between attendings that why it was not done. So please follow it. This is an interesting case that shows, you can do it many different ways. But again, you have to make sure, you have to be sure that you're not undermining, or you're not really doing anything wrong at one end, and you're not withholding some standard of care treatment. So these are the references. As I said, I want to thank, I have put references where I can. If I was unable to, I have just put credit to Google Image, but I want to thank all the authors from where I took these snippet and screenshots. So this is again a big thank you from everyone, and then these are my references. So I hope this presentation would help. This is just like walking you really fast on HIE. Pause the slide and read it at your pace. Okay, have a good day. Bye.